Well, the study is funded by AHRQ, and the first task that they gave us was to do a systematic review of the literature on basically preoperative care of patients undergoing cardiac procedures and total hip and total knee replacements. And we were supposed to look at the issues of preoperative nasal screening for Staph aureus carriage, MSSA and MRSA, methicillin-susceptible Staph aureus, methicillin-resistant Staph aureus, whether decolonization of Staph aureus carriers makes a difference, and then what perioperative prophylaxis should be given. And we were supposed to then do a meta-analysis of those papers and come up with a best practice algorithm that could subsequently be tested to see whether or not it was effective. The bundle will be screening of all patients preoperatively for Staph aureus carriage, both MSSA and MRSA carriage. If you're a nasal carrier of either MSSA or MRSA, you'll be given mupirocin if you're not allergic to it. If you carry MRSA, you will be given cefazolin and vancomycin as your perioperative prophylaxis for the antibiotics. And then all patients will be given chlorhexidine bathing before the procedures. The cardiac surgical procedures certainly are associated with a higher risk of SSI than the joint arthroplasty. So that may be the easiest place to actually see an effect of this bundle. But you know, if you get an infection in a joint replacement, that can be catastrophic. So I think the goal is to see whether in that patient population, if in a multi-center study, whether we can get enough procedures to see whether adding this bundle to, you know, really systematically applying it to everybody going through, whether that could drive down their already relatively low rates, you know, even further. Even the very highest surgical site infection rates, it's still a relatively small fraction of the total population. And so the question is, you know, if 90 to 99% of the patients don't get surgical site infections to begin with, do we add additional drugs which can add additional complications or expense to everybody to try to prevent those gram-negative infections, or can we identify a subpopulation who are much more likely to benefit from that additional antimicrobial agent?